I believe the CPAP is one of the best devices we carry on the ambulance to deal with airway issues. Next, coolest, one of the best devices we have dealing with airway stuff, and all real medical and trauma purposes, is capnography. So, for instance, how long do you think capnography's been around? So just take a second, ponder how long you've been seeing it in your research classes or this class or that or within your protocols. So Bob Page, kind of the father of capnography and EMS, wrote his first book and article on this in 1997. So that's kind of how long the thought of capnography and application of it's been in EMS. So you can see here a couple quotes from Father Bob Page himself. End-tidal CO2 reading without a waveform is like a heart rate without an ECG recording. So yes, we have the ability now to do qualitative and quantitative. Qualitative being that waveform that you see, and the quantitative seeing that numerical value. Also, in Ray Fowler, pretty infamous doctor, did a lot of capnography things, says CO2 is the smoke from the flames of metabolism. Just kind of an analogy to understand how it really applies to the body. If you don't believe my personal thoughts on it, here are some snippets that come out of all the American Heart Association standards of how important continuous waveform capnography is, and how it's reliable in confirming and monitoring tube placement, which historically that's what a lot of people think. Well, we use it for cardiac arrest, and now all these other purposes are coming out and how useful it is in other purposes besides just confirming tube placement and for adequate manual ventilations. So there's other studies showing that it's just pretty close or within just a couple points of being as close to ABG values on a large study that was done on a bunch of asthmatic patients. It showed that our qualitative and quantitative measurements we had were really, really close to what those ABGs show, which of course we all know those arterial blood gases, those ABGs, are the ultimate benchmark the hospitals do to evaluate their oxygenation and CO2 production and everything like that. Those colorimetric devices that we have on AMSs, just so everybody knows, those things are optional if you have capnography, and if you have that option, you need to take those colorimetric devices and just throw them in the trash. Just use capnography. Colorimetric devices are junk. Capnography is now the standard. And also one of the really, really good things for it is using it on evaluation of CPR. Granted, we can use it to assess ROS, if we get that sudden increase in end-tidal CO2, and we use it to measure evaluation of chest compressions and total CPR quality. So AHA recommends to have a minimum of 10 is your qualitative or quantitative measurement for what the minimum CO2 should be during CPR. So if you're seeing it any lower than that, the person pumping on the chest isn't doing a very good job, or if you have a mechanical CPR device, it's probably shifted off the xiphoid process and needs relocated. Or if it's just staying really low, that's another justification that it's beyond any kind of efforts that can be viable. So common field uses, we're going to use them on intubated patients that confirms tube placement. Granted, we can't go away from auscultating our patients still, but yes, we put that tube in, we get a good numerical value pop up on our monitor. That means the tube's in, we're getting some kind of CO2 return. But we still have to auscultate, because if we're going to intubate, a cardiac arrest patient, we got low numbers, it might be low because they've been down for a while, or it could be low because we've just right stem intubated them. So you still have that need to manually auscultate to make sure that you're in before the bifurcations are ventilating both lungs. And so we're going to use squares and numbers, that qualitative and quantitative measurements. Now, a note to know is with pediatrics, to confirm placement with them, since what kind of tubes we use on peds? Yeah, we're using cuffless tubes. So there's not as good of a seal in that little itty bitty ET tube we're using. So the qualitative and quantitative measurements on that can sometimes be skewed. So you can intubate a kid, get a CO2 number, and then it can go away, just because you don't have that good seal there and you got a small channel trying to capture all that CO2 volume. We also use it to ensure adequate ventilation. So the body measures CO2. CO2 is the main receptor or chemical that's measured to determine how well we breathe. So if the body measures the CO2 to evaluate itself, try to maintain itself, shouldn't we measure CO2 since we have that ability? We're using it on ventilating of the patient and how well we're going to ventilate the patient. We're using it to detect the patient's respiratory drive. So if we're assisting those ventilations and we can see their waveform up on there, then we can kind of get in correspondence with their ventilations to assist the ventilations instead of fight against them. If we're giving those patients narcotics or they're on drips, keeping them sedated and they're not intubated, we can keep them on that thing to tell how well they're ventilating, making sure we're not decreasing the respiratory drive. Or if we pick up that patient that's just overdosed on something, whether it's alcohol, any kind of drugs, heroin, whatever, we can still use that to evaluate the respiratory drive. So we might pick him up and he seems to be breathing okay. We get going down the road and that really rough riding ambulance that went out to the lowest fender, and we can't really tell if this 400-pound person's breathing or not because they got so much jiggle to him. But when you have them on capnography, you can see all that on the monitor to see if they're still breathing. In seizures, if that patient's doing the kick and chicken, we don't know if maybe they're breathing the whole time they're doing it or not. So maybe we need to go ahead and not wait that 2 minutes to go and give that patient the benzos to stop the seizures. Maybe we need to get them calmed down or at least try to ventilate them while they're seizing, because we don't want them to go 2 minutes without breathing. In CPR, we're using it to, as I said before, to ensure adequacy of the CPR, compressions and ventilations, and we're using it to evaluate return of spontaneous circulation. Another thing to note is capnography and pulse oximetry are not even in the same comparison bracket. So pulse oximetry, it just measures oxygenation only. So have you ever put a pulse ox on a patient that you have in cardiac arrest? Yeah, a lot of times if you're bagging them appropriately, got them intubated, they can have high levels of oxygen in their bloodstream. But does that mean that they're breathing well or they're necessarily perfusing well? No. So capnography is way superior to pulse oximetry. Granted, to each its own. And that pulse ox can commonly be skewed by some measurements that we need to be using capnography for. For instance, that pulse ox can be skewed by, as we all know, poor nail beds and nail polish. So the trick is to turn that pulse ox sideways, remove the nail polish, or whatever. Hypoperfusion, if that patient's hyperperfusing and not getting blood to their fingertips into those capillary beds, that pulse ox isn't going to pick up right. If their fingers are really cold, they got hypothermia, they just have overall poor perfusion from being anemic or anything, those are things that can skew that pulse ox. Gases, carbon monoxide can skew the pulse ox. Shows that they're at 99%, but they're still crazy short of breath because they have these asphyxiants in their bloodstream, such as carbon monoxide or CO2. So a lot of these respiratory patients pick up somebody short of breath. What's our evaluative measurement? We listen to their lung sounds and we put them on a pulse ox. But that pulse ox might say 96%. And their lung sounds don't sound too bad. And we're like, they're getting enough oxygen. But that pulse ox could be skewed in the same manner CO skews it by retaining CO2. A lot of our respiratory patients retain high levels of CO2. You can routinely have a patient very short of breath, minimal advantageous lung sounds, pulse ox reading within normal ranges, 94 to 99. They still just don't feel real good, still not breathing real well. Put them on a pulse ox, and now they're in titles in the 60s, 70s, 80s because they're retaining so much CO2. So then your little detective hat's on, like, oh, that's why their oxygen saturation looks good, because it's actually CO2 that pulse ox is picking up. So what capnography actually does, it's that partial pressure measurement of the CO2 at the end of expiration, because we exhale the CO2. So the CO2 device actually creates a small vacuum. So as we're exhaling, it's trying to suck that out. In the study I talked about before in 2005, the good numbers here to look at. Study in 2005. So think about the devices used to measure that in 2005. It's only gotten better. 39 asthmatics were within 1 millimeter mercury, and only 2 were outside of that 1 to 5 range of what their ABG showed as compared to what EMS capnography showed. So you're thinking about 2005. I don't even know what LifePak or Zoll's monitors were around then, but they're nowhere near comparison to what's around right now. Our normal capnography levels, 35 to 45 millimeters of mercury. Hyper, of course, anything above that. Hypo, anything below that. The devices we use to measure capnography for a capnogram, you have the nasal cannula one. It can also, some of those will double as an oxygen delivery method. Just remember, if you're using it as oxygen delivery, oxygen depletes your CO2. So if you're going to use that to measure qualitative and quantitative, maybe turn that oxygen off for just a few seconds, as that CO2 readings are instantaneous. They're not time-weighted averages by any means. They're complete instantaneous readings. So if you put them on that nasal prong, the prong is going in their nose, and it got one that goes over their lips. So if they're, a mouth breather, nose breather, it's still picking it up, and it'll evaluate all that. Then connect them to the oxygen and give them supplemental oxygen. When you do that, you'll generally see that CO2 range drop a little bit just from the washout of the oxygen. Then you have the ET cuffs that routinely go on our advanced airways, ET tube, King Airway, Combi tube, anything. Those can also connect into your capnography devices. But in studies that I have done and that other institutions have done, the best way to measure end-tidal capnography with a CPAP device is by those nasal prongs. Put the nasal prong on, then put the mask over them. Because as I said before, as that O2 washes out the CO2, if you put that ET cuff one in line of the CPAP, you got that high pressure, high flow oxygen going through that, it's going to deplete your numbers. Your waveform's not too bad, but your qualitative numbers are generally off by a decent amount. This is what your routine capnograph looks like. So as you see, your baseline plateau here, this is you inhaling. So as you exhale, that thing's creating that vacuum, so it's sucking, looking for CO2. So as soon as you exhale, that very first puff of CO2 as you exhale comes out. So you release a bunch of CO2 right away. Then as you continue to exhale, it slowly increases. So again, as you first exhale is when that waveform first goes up. And then as you continue to exhale slowly, then as you inhale is when it goes back down and goes back down to the flat line. With your capnography, some reasons that you may see hypocapnia. Commonly, those hyperventilating patients are blowing off a lot of CO2. So you got that person having an anxiety attack, you put them on there, and they're blowing off a bunch of CO2. So that can be found in some DKA patients, but generally they're still going to be within those normal ranges because they're so acidotic and they're retaining. They have a bunch of CO2 built up in them because they're so acidic. Cushing's reflex patients, they're hyperventilating because that herniation, or improper manual ventilation. You're doing that, you got that happy fireman just going to town, squeezing on that bag, and they're hyperventilating that patient, reducing their CO2. And as we know, when you hyperventilate, that CO2 blows off. When that CO2 blows off, your vasoconstrict. So as your CO2 levels go down, your vessel diameter goes down. Also, CHF, I have an asterisk there because in all the studies with CHF, there's no real good correlation in detecting issues with CHF with the use of capnography just yet. Hypoperfusion and shock, thinking about a Krebs cycle, you have oxygen plus glucose equal ATP. And what's a byproduct of ATP? CO2. So we can essentially measure energy production being put off by these patients. So if they are hypoperfusing, they're not going to have much energy production because that Stirling's law kicks into that too. For hypoperfusing, not much force to go in there to circulate all the metabolism stuff that Krebs desires to produce ATP. So if they're in shock or they have hypotension, one or another, they're hypoperfusing. If you hypoperfuse, your CO2 levels are going to go down. Pulmonary embolisms can be down because you're not getting that CO2 back into the alveoli to exhale them. That CO2 is going to be stuck in the bloodstream. So there is an example where that ABG is going to be off from our capnography because that CO2 staying in the bloodstream, we're not able to exhale it out. So you're going to see that CO2 being low. During CPR, most of the time in patients from cardiac arrest, they have very low ATP production, so not much CO2. Hypothermia, again, it's a form of shock and hypoperfusion, so there's a lack of metabolism and not much ATP produced, nor very much CO2. Some reasons for hypercapnia is bradypnea. If you hold your breath, your CO2 goes up. Just the opposite, if you hyperventilate, your CO2 goes down. If you're bradypneic, your CO2 is going to go, and of course that goes with apnea or complete ventilatory failure. You have that inability to blow off your CO2. And again, CHF. CHF can be a reason that your CO2 levels are high. It just depends on systemic wise really what's going on. The COPD patients, they're going to retain that CO2. So another good thing we can use that capnography for, that fear of reducing the hypoxic drive of patients. We can measure all that stuff on capnography. So if we're giving them those high levels of oxygen flow for long periods of time, we can be measuring to see if their ventilatory status is really changing. Acidosis, if the patient's acidotic, their pH drops below 7.35, you're going to have those low levels of CO2. So think about those septic shock patients. If they're septic, their CO2 levels are going to be low. Also, you can have an oxyhemoglobin dissociation. You got those anemic patients, everything else. You've just got reasons for poor perfusion, which again end up causing low CO2 when you don't have the ability for CO2 to bind and exhale out. Here's a good example of how ventilation and perfusion go hand in hand.
Alright, go.
So you got a bit of hyperventilation. Got one that already backed out. Can't hang. And here comes the lesson. So what do you think happened? So knowing what we know about anatomy and pathophysiology, so this youngster, his respiratory rate went up. So when your respiratory rate goes up, you're hyperventilating, you're decreasing your CO2. So you're blowing off hot CO2, and that CO2 also controls your blood vessel size. So as he hyperventilated, respiratory went up, CO2 levels drop, and the blood vessel size decreases. So now the brain hypoperfuses, and he went into sleepy timeout mode. And the opposite, if your respiratory rate goes down, your CO2 goes up, and your vessel diameter goes up. So now think about some of those anxiety patients we've had that have hyperventilated. And what do their fingers do? They get those carpal spasms where the fingers get all contoured and crunched in, and they get freaking out because they can't feel their fingers. Well, that's because they've hyperventilated and they have vasoconstricted, and now they've hyperperfused those muscles and they're spasming. Since we're talking so much about CO2, I'm sure a lot of people are thinking about measurements of that CO2 with use of end-tidal CO2 and capnography. So that is generally a direct correlation. They're generally within really close to one another. There was a study many years, or not many years ago, but a few years ago, of a whole bunch of respiratory patients, and what their end-tidal CO2 said was within about 2 to 5 millimeters of mercury of what their ABG actually showed. So a really good correlation, as long as there is not a VQ mismatch. And VQ mismatch means there's a discorrelation between ventilation and perfusion. So there's a ventilation perfusion mismatch. So one place you might see that is if you have you're doing waveform capnography and you see a low end-tidal CO2, but there's not an increased respiratory rate. Because if you increase your respiratory rate, you're going to blow off CO2. So there is a VQ mismatch there. So basically your two instances, or the two things that are going to cause that is there's a lung being ventilated that's not being perfused. So that there's air getting into that alveoli, but there's no blood getting to it to circulate all that through and to bring the CO2 back. Okay, or the opposite, you've got a lung that's getting perfused, but it's being hypoventilated. So that would be something like atelectasis or a COPD bronchoconstriction patient. Okay, so the big thing is if you see that VQ mismatch, to fix what's on one side or the other. Okay, so if that patient is believed to be hypoperfused by, weak pulses, cool, clammy skin, improve that perfusion. Give them some fluid or some pressors. If they have good perfusion statuses, good heart rates, good blood pressures, you don't see any signs and symptoms of hypoperfusion or shock, improve that ventilation. Give them some oxygen. Give them some volume of CPAP. Give them a bronchodilator to open that up. Give them that CPAP if it's atelectasis to create that PEEP pressure to open those alveoli back up. Give them a beta-2 agonist to get those bronchioles open back up. Give them some oxygen. Get rid of that VQ mismatch. So fix the ventilation or fix that perfusion. Because on mostly all of our patients, if they've got a normal respiratory rate, we should be seeing at 35 to 45 end-tidal CO2 range. If not, something's crazy, especially on that low end. So the low end is a VQ mismatch. On the high end, that's gonna be your respiratory patients who are retaining a bunch of CO2. So again, if you see low CO2 without hyperventilation, there's a VQ mismatch. Fix the perfusion, fix the ventilation. So with that said, that's a really good assessment tool if you do see the VQ mismatch to be assessing those airway issues or hypovolemia, sepsis, that patient with low end-tidal CO2, tachycardia and a fever, that's a septic patient. Or that patient who's mildly hypotensive but not hyperventilating who has a low end-tidal CO2. They're in the first stages of shock. Fix their volume. Fix the volume with the sepsis patients. Give them some fluid. If they're a COPDer and you see they got a low end-tidal CO2, but they seem to be oxygenating okay, go ahead and give them something to open them up. Get something in there, get that gas exchange going again. Here's an example of a waveform to evaluate. See the plateau here, so this is inhalation. Then you exhale. Short exhalation goes down. Long period before the next breath happens. And that wave gets just a little bit taller. Long wave and gets a little bit taller. And you see the respiratory rates, each pattern, it seems regular in between one another, but you can see the increase in those things, in your waveforms increasing. So your CO2 levels are increasing. So by the previous slide, we know that hypoventilation causes increase in CO2. So you can see this long drawn out period here. This patient is bradypneic and they are developing hypoventilation and hypercapnia. Here's another one to evaluate. So you have this plateau here. Same pretty regular, pretty regular, pretty regular. Same distance apart, same height. CO2 levels are the same. And then all of a sudden it gets really crazy tall, much higher. So these levels here might be 30, 30, 30, and all of a sudden it's at 80. And what do you think that is? Yes, that's return of spontaneous circulation. So all that CO2 that's been sitting out in the poorly perfused tissues has now gotten good circulation, gotten to the alveoli, and it's being exhaled all at once. So here, following is another good example of resuscitation in capnography. So here's a good example of how capnography applies in resuscitation. So here we are. This person is just emitting a little bit of CO2 while CPR is in progress. So CPR is in progress, a little bit of epi, more CPR, more CPR. CPR is just continuing. So you got a little bit of CO2 you're seeing there, retaining those low levels. You're around 12, 15 for CO2, You're still staying there. A little bit of CO2 is being produced, not too much. So you continue doing your compressions, keep evaluating qualitative measurements, keep giving them some more epi. So you get some more epi, or in this ether, a little bit of ether, some more CPR, keeping your checking your numbers. You're staying around 15 good high quality compressions. Then all of a sudden, bam! There's this high level of CO2 being produced, and now you check a pulse and your patient is alive. Another waveform to evaluate. So inhaling, the flat lines here, nothing going on. You exhale, but here that normal exhalation slow plateau we normally see goes downhill quite quick. So knowing that CO2 is suctioning, that is pulling in CO2, then all of a sudden it's got an absence of none there. What do you think is going on? In this instance, it means that there's a cuff leak. So in the same instance I talked about the pediatric cuffs not being able to make a good seal and not having good qualitative or quantitative measurements, the same thing here. So if you're ventilating that patient, you'll probably notice a resistance unless you're on a mechanical vent, but you would see the cuff leak that is not getting a good seal to create that vacuum to pull the appropriate levels of CO2 in. Continuing with the trend, another waveform to evaluate. So flatlined, nothing going on, then all of a sudden exhale, CO2 production, but it's coming out not fast like it should. It normally comes up pretty fast, then a plateau, but this is releasing really slow. There's not that sudden surge of CO2 being produced or being able to read. It's slow release of CO2 and then back down. So what do you think causes that? That's bronchoconstriction. That air's being trapped in, so as that CO2 is getting alveoli to be exhaled out, this bronchoconstriction is limiting the amount of exhalation volume that can occur, so that CO2 is being trapped. Similar to squeezing the stem of a balloon and having that squeaking sound, the air being trapped, coming out very slowly, is bronchoconstriction. Here are some more examples of different waveforms. So starting at the top here, that sudden loss of waveform could mean you've disconnected your ET tube, it's become dislodged, or your capno line has become plugged with something. You're decreasing CO2, developing these weird waveforms. Again, not a good seal, so you've probably got a cuff leak or you've blown the bulb in whatever tube you're using. Your CPR assessment, making sure you got good qualitative and quantitative measurements here. And again, AHA recommends to stay above 10 millimeters of mercury for adequate CPR. A sudden increase in CO2, again, that's resuscitation. That shark fin appearance of bronchoconstriction from asthma or COPD. Those long, drawn out, increasing in height waveforms is hypoventilation. Then the opposite, shorter, closer together, decreasing in size, hyperventilation. If you just see weird stuff all around, apnea. If you've got weird waveforms, then good plateaus, weird waveforms, probably that patient's being sedated, possibly trying to breathe over the tube, or just not having good respiratory drive. Now let's talk about some examples and some cases. So in case number one, you're responding to a patient who's had major bleeding from a traumatic injury, and now the bleeding is controlled. You've assessed them. The blood pressure is 78/40, respiratory rate is 28, 91% on room air, heart rate's 126 sinus tach, end tidal CO2 of 18. They're pale, cool, diaphoretic with an altered mental status, a GCS of 445. So what's your treatment and your differential diagnosis for this patient? Hopefully that treatment differential diagnosis is they are hypoperfusing, they need a large bore IV and fluid replacement. So you started that large bore IV, you've administered fluids, you got your handful, you're in transport to a trauma center, and you just haven't got time to get that blood pressure just yet. But all your instantaneous readings are telling you that you've got a respiratory rate of 22, because your capnography will tell you the respiratory rate. You have a pulse ox reading of 96%. Their heart rate has come down to 106, and her end tidal has increased to 30. Do you think your treatment's working? The answer is yes, it is. For one, you're reducing that compensatory mechanism on the heart rate, so the heart rate's coming back down, and the CO2 is increasing. So that means you're increasing that perfusion that's helping increase that ATP production. So that oxygen and glucose is working, producing ATP. Now your CO2 levels are increasing as well. Case number 2. Swallowing tube patient who's post-ictal seizure transport. Their BP is 116/80, respiratory rate's 15, they're 98% on room air, blood glucose of 142, heart rate at 86, normal sinus rhythm, end tidal CO2 of 38. They are pink, warm, and dry. What's your treatment differential diagnosis for this patient? Now let's say that patient begins to demonstrate tonic-clonic seizure-like activity. They're doing the kick and chicken. And since you already had your capnography hooked up, here's the waveform that you're seeing. So they were at 40, staying at 40, and now you're seeing this long, prolonged, little squiggly lines down here. So is your patient breathing? No. Do you think it's possibly time to start intervening and giving benzos or something, or you want to let our patient go apneic for 2 minutes? Next case. You got a patient who has a traumatic brain injury from a fall. They've got an altered GCS at 224, hypertensive at 210/128, respiratory varies 12 to 30. They're having ataxic Shane-Stokes respirations, 95% room air, blood glucose is 102, heart rate sinus Brady of 48, their end tidal is 45. What's your treatment and differential diagnosis on this patient? So treatment, differential diagnosis. Yeah, the patient is herniating. They are hypertensive bradycardic with ataxic respirations. That is Cushing's reflex. So with that Cushing's reflex, signs of herniation, how do we want to treat that patient? Yes, we control the airway. If there are signs of impending central nervous herniation, increased BP, bradycardia, decreased GCS, dilation of pupils, paralysis, decerebral or decortical posturing, ventilate the patient 12 to 20 breaths per minute, maintain an end tidal CO2 at 30 millimeters of mercury. This was pulled straight out of the West Virginia protocols, which is verbatim of what PHTLS says. So we need to monitor capnography in trauma patients as well. Next case. You have an adult who's experiencing difficulty in breathing. They've got a history of COPD and CHF. Have a GCS of 456, blood pressure is 142/96, respiratory rate slightly labored at 25, 90% on room air, blood glucose of 102, heart rate is 66, end tidal CO2 of 45. Their lungs are shallow and diminished. What's your treatment, differential diagnosis for this patient? So with that patient, what's your differential diagnosis? You see this waveform here. You're having a really hard time oscillating because it's diminished. You're in the back of a bumpy ambulance, but you see the shark fin appearance. So do you think this is CHF or COPD? Yeah, you see the shark fin appearance. There's bronchoconstriction going on. Still, on a side note, both could be occurring simultaneously, but generally this can be your bronchoconstriction and you treat it accordingly. In closing, just remember, the body measures CO2, so we should too.